Hello, everyone. Thanks for joining us for today's Q&A webinar that will help you understand new COVID-19 telehealth regulations. We'll have a brief presentation followed by the Q&A. So if you would like to ask a question, you can type it into the Q&A box on your screen. In the box at the bottom of your screen, you can download a copy of today's slides. The recording of this webinar will be posted on our COVID-19 resource page, which is accessible by going to our homepage at diabetieseducator.org, and we'll also have a direct link for you at the end of the webinar. With us today are Chris Keelan from the Billings Clinic in Miles City, Montana, Patty Telgener, Vice President of Reimbursement with Emerson Consultants, and ADCES's reimbursement expert. And from ADCES, we have Leslie Kolb, Chief Science and Practice Officer, Sasha Ullman, Director of Diabetes Education and Prevention Programs, Kate Thomas, Director of Advocacy, Kirsten Yale, Research Manager, and Joanne Rinker, Director of Practice and Content Development. So I will throw it over to Joanne.
Thank you so much, Megan. So first and foremost, to kick us off, Leslie Kolb, our Chief Science and Practice Officer, just wants to take a moment to say a few words.
Hi, everybody. Thank you for joining us today on this World Health Day. You know, supporting each other has never been more important. In some ways, we have never been so isolated, and yet in other ways, we've never been more united. This is a very different time we're working in right now. I heard colleagues say today, the future is now. And where she was going with that is that technology has been growing in so many ways in the past, and now all of a sudden, in some cases, we're finding ourselves 100% virtual and trying to learn how to do our work and live and pray in some cases. Everything that we're doing now is we're trying to come around with a new way of doing that, and that's virtual. I just wanted to take this time to thank everyone who's been posting on the COIs with such great information. I read Marianne Strobel's the other day, and she's posted on how we can contribute and how our unique interprofessional skill sets can meet the needs of the individuals we serve. And I just feel like it really kind of tuned into the fact that we really are all in this together, and we thank all of you for everything that you are doing, and hope that these Q&A sessions continue to help clarify some things. Thank you, Joanne.
Thank you, Leslie. So we're going to kick it off with Sasha, and Sasha is just going to do a couple of updates for us.
Sorry, got to turn off mute to do that. Thanks, everybody. So we are going to go through, I have a couple questions that have come up that we wanted to share. So one of them is in the telehealth guidelines. There is this other designation that says registered dietitian and other nutrition professional. So I think a lot of people, including myself, thought, what does that mean? And so we dug a little deeper. And so this is the definition. We were kind of hoping that it might expand telehealth to some of our colleagues who are doing diabetes education, but the definition is actually, as most of us dietitians knew, it sort of goes along with MNT, that this other professional is someone who holds a bachelor's or higher degree and completed the academic requirements of program in nutrition and dietetics, has completed the 900 hours, and is licensed as a dietitian, licensed or certified as a dietitian or nutrition professional. So I don't think there's anything new there. We did dig deeper just to see if that might glean some new information, but it is essentially registered dietitians is the definition. And then some updated information regarding billing for the SMT through telehealth, or in general billing for telehealth. But Medicare has given some additional guidance. So a couple things to clarify. DSMT or DSMES would still be billed under the program NPI number. Okay, so it's not the dietitian's own NPI number necessarily. It's whatever you're normally billing under for your program, and that accreditation or recognition certificate is what is how that gets billed. So that is where it goes. And you're using the same codes, G0108 for one-on-one or G0109 for group. Prior to March 30th, CMS was advising the place of service code of 02 for the modifier. As of March 30th, they're asking people to report as if the services had been provided in person. For example, using the POS 11 modifier to indicate a service that would have been provided in office, and also reporting the 95 modifier for the telehealth. So that is the information. So the 02 modifier is not incorrect, but they're giving this additional guidance for you. I'll turn it back over to Joanne.
Thank you, Sasha. So next up, Kate is going to talk to us a little bit about pumps and CGM coverage.
Hi, thanks, Joanne. And I'm happy to report that we've gotten some additional clarification. I know that there was a lot of concerns about some of the face-to-face requirements for people getting supplies for CGM or insulin pumps. And CMS, in their interim final rule comment released on March 30th, announced that they will temporarily waive face-to-face requirements for coverage of CGM supplies, insulin pump supplies, and test strips. So that was an important announcement that we saw, and we have updated our documentation accordingly. Also, something of interest on the insulin pump side, CMS is saying that they will not enforce the clinical indications for coverage for certain policies, and they do specifically list the national coverage determination for insulin pumps and the local coverage determination for insulin pumps. So these are important things, recognizing that people aren't able to get to face-to-face appointments, and so making some consideration that those can be done via telehealth, and that CMS will not enforce some of the clinical indications for insulin pump policies. They want to ensure maximum flexibilities for both providers and beneficiaries.
Thank you, Kate. So next we're going to move to we wanted to show the group our telehealth, our brand new telehealth page. So I know this takes a little bit of switching around to technology, so bear with us for just a second. Okay, so what I'm sharing here is I'm just showing you, this is our telehealth page, but actually went live earlier today. And this page is a little bit different. If you want specific COVID-19 and telehealth updates, you just click this link here that says telehealth and COVID-19. And then the rest of this page is understanding telehealth sort of broadly. So this is, we had a variety of members who were kind enough to send us short videos about things like how should my client prepare to receive virtual DSMES, what does the diabetes care and education specialist need to know to start delivering virtual DSMES, teaching tools, etc. Then we have all of the telehealth platforms here where you could click on each platform and get some of the specs for each one. So the benefit here is that many of them are actually doing some free trials, and so it gives you an opportunity to not only identify a platform for you and you as a professional and your practice, but also for your population to see which one might be best for you. So you can just click on one of those and kind of explore some. Additional resources that we added here were the COIs that are sort of connected to telemedicine. And then we also have resources for people with diabetes. So this is those 10 tips to help prepare for a telehealth appointment. This could be something that you're sharing with the people that you serve, and you could download that right there. We also have huddle conversations. So these are those live audio conversations that we have with people who are already putting telehealth into practice. We have a variety of recorded webinars and online courses about telehealth or getting reimbursement. And then we do have journal articles from both ABCES in practice and TDE, which is our Diabetes Educator Journal. And then lastly, we have additional readings. And I would like Kirsten just to take a moment to review some of these and how they landed on this page.
Sure, and I'll go pretty quick, and if anybody has any questions about this, just please jump in at the end. I'm happy to answer them. So we just started this. I would consider this a work in progress. And these are really research resources we're putting together to support you guys in developing and implementing telehealth programs in your health system. So maybe if you're submitting a proposal for like a grant proposal to implement telehealth, so these would be great resources for that. Or maybe you need evidence-based literature to go to your leadership to convince them and show them how like the evidence that telehealth does work. So that's what these resources are really for. They started with a lit search that we did. It was a pretty broad lit search covering technology and the diabetes care and education specialist. And what we did, it was like I said, broad lit search, looked at hundreds of publications. And we had a whole team of members from ADCES that went through and then tagged all of those publications, and we were able to pull out the telehealth ones that way. So I have, if anybody wants it, feel free to reach out to me. We have, for over those 2 years, we have about 46 publications, and specifically for telehealth, there's more for remote health if people are interested in that. That might be for another Q&A. But out of those 46, the important ones that we're putting up here on the page are the systematic reviews. So there were 6 systematic reviews out of those 46. And, what systematic reviews do is they're pretty important from a broad perspective, where they look across a range of studies. They look at, randomized controlled trials, qualitative, quantitative studies, and they pull out the pertinent data, right? So they extract the pertinent data, and you can see, so instead of just looking at one small randomized controlled trial, you can look at many randomized controlled trials all in one paper. And so really what they do is they give us an evidence-based snapshot of where research is right now and where the gaps are. And they tend to be what I call in the research world the call for action in the research world. So I'm going to stop there. I just want to let you guys know that it's there. If you need evidence-based research, you know where to find it. We're going to keep updating it. And we are doing a 2020 update to the Greenwood et al. Systematic review that you see at the top there. So I think that's it. Joanne, over to you.
Perfect. Thank you, Kirsten. So now we're going to transfer back to our slide deck. And then I'm going to turn it over to Leslie just to talk a little bit about the updates that have been happening in reference to private payers.
Okay, so the last time we spoke, there were some questions around what are private payers doing in telehealth. And I just wanted to let people know that we do have a system called Canary Insights that we receive daily updates from payers, anything that's publicly posted out there and things that are going on. These next 3 slides are just information for you all to share, since you are able to have these slides after the conference call, that point out the telehealth services that each of these payers are now, the guidance that they've put out there. My plan is that if we will continue to have these calls every Tuesday, and we'll get more information on that. And as I get new updates from the private payers and what they're planning on doing, I will make sure that all of you receive them within these PowerPoint presentations, and you can click on those links. Thank you, Joanne.
Thanks, Leslie. And then the next slide is a slide of telehealth resources. We'd actually had this in some previous slide decks, but I left it in there just because I think it's good as a reference. If you're only watching this Q&A session, I didn't want you to miss it. And then the last 2 slides before we do a few of our questions from our Q&A is I'm going to turn it over to Kate just to share with us a couple updates.
Yes, so I wanted to update people on some resources related to Medicaid information. The Center for Connected Health Policy has a really great interactive state map. If you go to their homepage, you can access it very easily there. It can help you see what the Medicaid changes have been in your state and any other relevant links or information. So if you're trying to find the right contact, I find this to be a really strong site. I also included a Medicare resource related to COVID-19, it's Medicaid's page, and then also the list of states that have applied and have been granted 1135 waivers. So hopefully you can use this as a resource tool.
And then, Kate, do you want to talk about the call to action?
Sure. One of the biggest outstanding issues that we're facing and we're hearing from our members about is the fact that registered nurses and pharmacists are still not included on the list of healthcare providers eligible to provide DSMT via telehealth during the COVID-19 pandemic. And we've been doing a lot of behind-the-scenes advocacy work with CMS, with some of our other partners on a number of issues, this one included. And we wanted to open our call to action up to our members to share your story with CMS. So if you follow this link, it will take you to our Legislative Action Center. You'll find a pre-populated letter with some information outlining what the issue is. You can add your own perspective, why this is important, the impacts this has on people with diabetes, and you can send that off. Those letters will go to the 1135 waiver mailbox, and CMS will receive them directly. So we're hoping that we can generate some additional attention to really bring the focus to this issue. And that's it, Joanne. Thank you.
Thank you so much, Kate. All right, so let's jump into some questions that we have from the listeners. So can consent be given verbally and then documented, or does there need to be a physical signature still? And I'm going to turn that one to Chris.
Thank you. So the consent for telehealth, I've been instructed in my facility, and we've reviewed this and looked up some of the data on this. It does indicate that we can get a consent. I do this with my patients. Do you consent to audio-video telehealth? My patient says yes. I document that in my note, so I don't need to get an actual written signature from the patient. The old standards for healthcare, or for telehealth, we always did that going into a site, and they all call it the old-fashioned way. But this, we can get a verbal consent. We put that in our note as the, in my case, RDN provider providing telehealth DSMT, and that is satisfactory as consent.
Thank you, Chris. My next question, I'm going to direct it to Sasha. Are there any updates to RNs, CDEs to be able to bill through CMS?
So that's a good question, and I think Kate covered sort of our call to action right now. We have not heard back on that, and we are continuing to reach out and communicate with CMS about that. I will say that if you are in a situation, in an organization that supports you to do this, there's no penalty for reaching out to your patients by phone or telehealth or virtually. It's a reimbursement issue that RNs and pharmacists weren't included. So I want to be sure if people have the capacity and the support of their organization to do this without reimbursement for now, you can do that, and those can be documented as a accredited program for DAP as far as your numbers. So I hope that helps a little bit, and we will continue to press this issue.
Thank you, Sasha. My next question is for Kate. Are there any updates on billing for FQHCs?
That's a great question, and I feel like I wish I had more information that I could provide. So when Congress passed the CARES Act back on March 27th, they did write language into the bill that ultimately became the law to expand reimbursement for FQHCs. So we expected for CMS to act relatively quickly on this provision. We were hoping it would come out in the March 30th guidance they released, but it didn't. So we are still awaiting further clarification and guidance from CMS to see how this actually plays out and what you need to know in terms of setting this up at your FQHC.
Perfect. Thank you so much. And then a next question we have here is, I think this is a good one for Sasha. For patients without computer or smartphones, can we use telephone for telehealth? Is it covered by Medicare?
So that's a good question. As far as we know, it is not covered. You need the audio and video. They need to have an audio and video phone, which would be any phone that allows them audio or video, or a computer or some way to have a device that's audio and video. There are other codes that may be used potentially, but none that we know of for MNT or DSMT.
Thank you. And then I have a few questions for Patty. So Patty, let's start with the UB04. Are there any updates with the use of that form?
As far as the UB04, it is recommended that providers continue to use the same form that they were prior to any of these changes. So if you were billing under the UB04, you would continue. If you were billing under the CMS 1500, you would continue as previous. If for telehealth under the UB04, the revenue code 780 would indicate that that was provided via telehealth, whereas the place of service we're seeing more on the CMS 1500. But 780 revenue code on a UB04 would indicate that that was provided via telehealth.
Thank you, Patty. And then a couple other questions for you. If the physicians are using telehealth for a patient visit and they request a consult from the diabetes educator the same day of the visit, is that allowed?
Can you repeat that? I'm not quite sure if I understood the question.
Yeah. So if the physicians are using telehealth for a patient visit, and then they request a consult from the diabetes care and education specialist the same day as that visit, is that allowed? Can I have telehealth by the provider? And
Yeah. I believe it would, and the reason why is that when you said a consult, I'm assuming that they would bill for DSMT or MNT, and the physician most likely would be billing a different telehealth code. Again, I would highly recommend that there's very good documentation as to why both services are provided. There is a risk that if they're both under the same MPI that they could only pay one. But I think with kind of everything that is kind of changing right now, I think it would be okay with appropriate documentation, and especially if they're under different MPIs.
Great, thank you, Patty. And then last one for you at the moment. If a patient attempts to do a virtual visit but struggles to get audio-video connection, and then the visit transitions to a phone visit, are we able to bill G2063?
I mean, there are so many kind of, gray areas here, and this would be one of them. First of all, G2063, is not a code that would be used specific for DSMT. That is for an assessment code for qualified healthcare professional. But in the question, if they're only able to do one of audio, if audio didn't work and was only, or if audio did work but visual did not, that is going to have to come down to each provider and document that it was attempted and now it was only phone because of lack of connection. But again, the requirement sometimes does require both of them. So again, document and really just make sure that that those codes are being followed correctly. I know it's kind of a roundabout answer, but it's a gray area.
Yeah. Thank you, Patty. Okay, next one is for Leslie. If CMS denies RN DSMT, then why are RNs allowed to be CDEs? This is a true disservice to the profession.
Thank you, Joanne. So this question very interesting. And actually, I just find it interesting. So being a CDE has nothing to do with billing, whether you're an RN or an RD or a pharmacist. In fact, being a CDE doesn't change your scope of practice. Having a CDE speaks to the expert level of knowledge that you have in diabetes self-management education and support. It's the same with the BCADM. neither of those credentials change how you bill or change how you provide your service to the people that you're working with. So I really can't answer that question because the two of them are not connected, other than to say that, you know, we're an interprofessional group of passionate, dedicated people who work with our people with diabetes every day, and what's complicated by some of the Medicare regulations and by some of our systems and the UB04 and the 1500s, but we can do this together, I promise you that. And as soon as we get the answers from Medicare on the RN and the pharmacist, as well as the UB04 information, we will get it out to you as soon as we can.
Thank you, Leslie. And then I just have two more questions for Sasha before we wrap up. So if the educator is working from home, does our DIEP program need to add their home as a community site when doing telehealth?
Yes, we're asking that our DIEP programs do add a community site. We're not going to ask for an address or anything, just so that we can be aware of those of you who are providing telehealth. And this helps make sure that we are letting CMS know that we are aware of what you're doing and that this has been kind of approved through us. So yes, please do send in a request to add a community site. There's no charge, and you can just list home. We don't need an address.
Okay, perfect. And then the last question, are we able to conduct group classes via telehealth using GO 109?
Yep. So it's the same process, and it's just that different code. So if you have the capacity and the software and the ability to do group classes via telehealth, you can. Keep in mind that the same documentation is required, and an individual, assessment is required. So you will need to make sure to do the same documentation as an in-person group class for DSNES for accredited programs. But yes, you can do group using G0109.
Perfect. Thank you so much. And then it looks like Chris wanted to add a little bit more clarification on the G2063 code.
Yeah, if that's okay. I just wanted to, I know we're all looking for ways to capture something that supports a revenue generation, but with the G2061, G2062, G2063, those are time-based codes generated for use specifically with communication via a patient portal. So really the electronic communication would be intended for gathering data that comes through a safe patient portal and where we can communicate back to the patient that way. Those are the ways the codes are used in my facility, and the RDN is doing that, and it is billable, but not via telephone. We wouldn't use those codes. It doesn't speak to the intent of the codes.
Perfect. Thank you so much, Chris. And thank you to all of our presenters, as well as everyone who participated by putting some questions in our Q&A box and keeping all of us informed. I'm going to turn it over to Megan to wrap us up, and I hope everyone stays well.
Great. Thank you. Thank you all for presenting and answering the questions, and everyone for participating in today's webinar. This webinar was recorded, and we will post it on our COVID-19 resource page, and the link to that is in the web links box that you see on your screen. And we also added a link to the COVID-19 discussion on my AADE network. Again, you can download today's webinar slides through the box in the web links, under the web links box, excuse me. And we'll leave the webinar room open for a bit so you can check out those links and download